Hello, everyone, and welcome. My name is Kristen Reed, and I am a research coordinator here at Health Evidence. We're very pleased today that you're able to join us to talk about the effect of tobacco control policies on perinatal and child health. I will be introducing in a few moments Dr. Jasper Been, who we are thrilled to have joining us today to present the findings of their recent systematic review. We would like to take this time to wish a warm welcome to our presenter today and also to welcome all of our health evidence users that have joined us for this webinar. So throughout the session today, we will be posting polling questions on the WebEx platform. Your participation in polling questions is voluntary and anonymous. So I'll just leave this consent slide up for a moment, and then I will move on shortly. So just to let everybody know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week or so, and the links to both of these resources will be posted in the chat section. So today we're very excited to be talking about the review, Effective Tobacco Control Policies on Perinatal and Child Health, a systematic review and meta-analysis. The link to the Health Evidence Review page for this systematic review will be posted in the chat section, so you can click on this link and follow along in the review using the article full text or PubMed link out. We'll also post the direct link to the full text article in the chat box. So just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host. Also, please feel free to post your questions and comments throughout the session, and towards the end of the session, we will save some time for the presenter to respond to any questions or comments that you might have. For the best connection, we do recommend you use a wired internet connection versus a wireless connection, and should you have any connection issues, we have posted the 24/7 WebEx helpline on this slide, as well as in the chat section. For your audio today, we ask that you please listen through your speakers. If you are having trouble hearing or experiencing feedback, you can go to Communicate at the top bar in WebEx and then click on Audio Broadcast. So we have our first polling question of the day, and this can be found on the right-hand side of the WebEx platform. And we're really wondering just how many people are joining us today. So are you joining just yourself or in a group of 2 to 3? 4 to 5, 6 to 10, or perhaps you're joining in a group of over 10. So I will just leave that up for a moment, and it looks like most people are joining by themselves today or on their own, and a couple in small groups too. So that's really great. So I will move on shortly here. So we would also like to give a special thanks to our health evidence team who have worked to bring this discussion to you today. There is a large team of us who work to keep health evidence current and maintained, as well as to coordinate our webinar series. For those of you who may not be familiar, Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 4,800 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of health evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. The value add for using health evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. So we have done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for evidence-informed decision-making available online. And many of our users have informed us that our tools and repository are both easy and simple to use. So I'm just going to quickly touch on the model for evidence-informed decision-making, which we can hopefully keep in mind as the presenter goes through this systematic review today. This model consists of 5 components that you can see here in the diagram. Traditionally, public health practitioners and decision makers consider evidence about community health and issues in local context, existing resources, community and political climate, and making decisions about programs and policies. However, it's become apparent that considering evidence about research can be challenging to integrate into public health practice. And as such, the Health Evidence webinar series is designed to highlight research evidence relevant to public health decisions. So on this next slide, we can see the stages of evidence-informed public health that illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. There are 7 steps outlined here that you can see, and today we'll be focusing on how the presenter has worked through the first 4 of these steps in order to help public health decision makers with the remainder of the steps in this process. So we have our second polling question here, and what we're wondering, how many participants here today have heard of or are familiar with the term PICOS? So I'll just leave that open for a few moments, and just a reminder to click the submit button in order to submit your response. So as people are answering, I think quite a few are familiar with this term PICOS, but we do have a few that are less familiar with this concept. So I'll just take a few moments for those of you who aren't familiar. PICOS is a way for you to structure your research questions. It involves defining who the population is that you're interested in, what the intervention, program, service, or policy is that you want to know about, the comparison group, if any, and outlining the specific outcomes you're looking for. And then also, sometimes we also have a particular setting in mind, which we can also state here. So, for example, a school or community setting. So the value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and can then help you to search for relevant information related to your PICO more easily and efficiently. So one final polling question that we have before we get started is we'd like to know, how often do you use systematic reviews in your practice to inform a program or service? And so either always, often, sometimes, never, or perhaps you're not really familiar with what a systematic review is. All right, thank you so much for your responses. We're seeing that most people or some people always or often use systematic reviews in their work. We do have some sometimes and never as well. So hopefully we can give a little bit more information about that as we go through today. So I will move on to introducing our presenter. We're really excited to have Dr. Jasper Been today to present the findings from their systematic review. Dr. Jasper Been is a consultant neonatologist at Erasmus University's Children's Hospital and an honorary research fellow in the Center for Medical Informatics at the University of Edinburgh. So thank you very much for joining us today, Jasper, and I'll pass it along to you to get started.
Well, thank you very much for your kind introduction, and thanks for joining today. I'm very excited about being able to present here, which is actually my first webinar. And I want to start by just explaining the scope of the problem that we're talking about. So starting to outline the tobacco problem that we have in the world. There's over 1 billion people who are regular smokers in the world. And of those people, an estimated 7 million die each year prematurely due to a disease related to smoking, making smoking one of the most important preventable causes of disease and death across the globe. And this costs us as a society over $1 trillion US each year in economic costs. And whereas these figures mainly relate to the trouble that tobacco causes among adults, smoking also affects children, and children themselves cannot regulate their own level of exposure. In high-income countries, up to 20% of all children are exposed to tobacco smoke while in the womb via their mother smoking during pregnancy. And when they are born, up to 40 to 50% of all children across the globe are regularly exposed to tobacco smoke. So there's quite a few children that are exposed, and they are experiencing adverse health effects of this smoke exposure. And this has been estimated in a paper published in the Lancet a couple of years ago, where the authors showed that due to respiratory diseases caused by secondhand smoke exposure, over 160,000 children die each year because of this. And even worse, if you express it in DALYs, which is sort of a measure to express not in deaths but in loss of healthy life years, over half of the DALYs occur in children when it comes to the effects of secondhand smoke exposure. So what does secondhand smoke exposure do? Well, if the mother smokes during pregnancy, there's an increased risk of the baby being born preterm. There's an increased risk of the baby being born with low birth weight, having congenital anomalies such as cleft lip and cleft palate, being stillborn, so not surviving until birth, or even dying after birth. And it's not just ending after birth. And luckily, a lot has changed over the last few years, and we no longer think that it is sexy to be blowing smoke into someone's face. But still, as I said, 40 to 50% of children are regularly exposed. So after birth, this increases their risk of dying in infancy. It increases their risk of having severe asthma attacks, having lower respiratory tract infections, having invasive meningococcal disease. And in addition, over recent years, it's been shown that if children are exposed to tobacco smoke before or after birth, they have a higher chance of becoming smokers themselves. And they will be raising the next generation of children who will then also be exposed.
Sorry, Jasper, sorry, I apologize to interrupt. We just have a request if you wouldn't mind trying to speak a little bit louder into the phone. Sorry.
Yeah, sure. I'll just try it by the phone itself. Hopefully this is better.
Thank you. I apologize for the interruption.
No worries. So the scope of the problem is clear, and in combination with the impact on adults, the WHO has initialized a international framework, the Framework Convention on Tobacco Control, to tackle the global tobacco epidemic. And as you can see, there's now actually 181 countries that have ratified this treaty. And to make this more practical, the WHO came up with the MPOWER set of tobacco control measures, which is an acronym standing for 6 sets of tobacco control measures that countries which have ratified the FCTC should be implementing in order to control the tobacco epidemic. And I'll quickly go over these because these will be the subject of our systematic review. And these include the country should be monitoring the use of tobacco in their population and the implementation of tobacco control prevention policies. They should be protecting people from tobacco being smoked by others, which is mainly done via making public places smoke-free. They should be offering people help to quit tobacco smoke if they would want to quit. Governments should be warning their population about the dangers of tobacco, and luckily we see this now more and more when going to shops. This actually is my personal favorite from Canada. Governments should also be enforcing bans on tobacco advertising, promotion, and sponsorship. So tobacco companies should no longer be allowed to influence policy and to advertise their products. And lastly, and probably this is the most effective policy when it comes to smoking rates in adults, the country should be raising the taxes on tobacco. As I said, most of these MPOWER measures are primarily aimed at adults and at smokers. But I also indicated that children are also vulnerable to tobacco smoke. And therefore, we looked and published in 2014 in the Lancet whether smoke-free legislation, one of the MPOWER measures, has an impact on children's health. So protecting them from secondhand smoke exposure, does it help improve their health? This is when we performed a systematic review, which is actually a literature review of all the published literature on a certain topic, which is then systematically analyzed. And if possible, you can combine the data from the different studies using a statistical technique called meta-analysis. We found 11 studies at the time, carried out in North America and Europe, as you can see. And these encompass data from 2.5 million births and about 250,000 hospital admissions for asthma among children. And when we combined the data using this meta-analysis, we were able to show that if countries implemented smoke-free legislation, the number of preterm births dropped by 10%, and also the number of hospital admissions for asthma among children dropped by 10%. Taking this work forward, and this is actually the work that I'll be presenting on, we thought we should be updating this evidence, and we should also be broadening its scope. So we didn't only look at the impact of smoke-free legislation, but we also evaluated the impact of other tobacco control policies on children's health. We made a protocol for this study, which we had peer-reviewed and published before undertaking this work. And we sought to look for studies looking at the association between MPOWER policies and perinatal and child health. We only selected those of the highest quality design as set out by the EPOC group as part of Cochrane. We searched 14 online databases, including grade literature, which is a term used for government documents and PhD thesis. And we also looked for data from studies that hadn't yet been published. Among the studies that we identified, we checked for their references and citations to add any more studies. And we also consulted experts in the field to see if any studies had been missed by us. We thought that these were the outcomes that mattered most to children and were most amenable to changes in secondhand smoke exposure. And these were perinatal mortality, so dying before or shortly after birth, preterm birth, hospital admissions for asthma, and hospital admissions for respiratory tract infections, again, all among children. We had our search performed independently by 2 reviewers who used customized data extraction forms to get the data from the studies and contacted authors of the studies if any data was missing. The studies were quality assessed using risk of bias criteria, and if possible, the data were pooled in meta-analysis, as I indicated before, and as I will show you in a couple of slides, and we excluded studies that have overlapping populations. We also looked whether our findings were sensitive to excluding the studies that had a higher risk of bias and including studies that weren't of the highest quality. Furthermore, we looked at whether not only did the MPOWER policy have an impact, but was the impact bigger if the policy was more comprehensive? And we also looked at whether the policies had any specific impact among socioeconomic groups. As most of you will know, smoking is much more prevalent among lower socioeconomic groups, at least in high-income countries, and we were interested in whether the policies can help reduce these inequalities. We screened among the 14 databases over 12,000 records of studies, and from those we extracted 44 studies which were included in our qualitative synthesis. Most of these studies were on the impact of smoke-free legislation, a few were on tobacco taxation, and 3 were on offering help to quit tobacco use and whether this impacted children's health. Among the 44 studies, 26 were amenable to pooling using meta-analysis. As already indicated, the study was published in September last year in the Lancet Public Health, so you can read about it if you like after the talk. These are the regions where the studies were conducted, and as you can see, they were conducted in North America and in Europe. European studies typically were country-wide policies, whereas North American studies evaluated local policies either at the state level or at the regional level. And there was one study from Hong Kong and China. Altogether, the studies included over 50 million births, almost 5 million consultations with general practitioners, and over 2.5 million hospital admissions among children. And I will now discuss our findings. First, I will discuss the findings on smoke-free legislation. And one of the primary outcomes was perinatal mortality. We identified 2 studies that looked at the relationship between smoke-free legislation and perinatal mortality. There was one study of almost 2 million births carried out in the Netherlands, where smoke-free legislation was not particularly comprehensive, but was introduced in a phased manner. We did not see any changes in perinatal mortality after introduction of the smoke-free law. In a much larger study in England of over 10 million births, where a smoke-free law was introduced in a comprehensive manner, we noted a significant reduction in the number of babies dying before birth and the number of babies dying shortly after birth. This is the first meta-analysis that we were able to perform, showing the studies done on the impact of smoke-free legislation on preterm birth. On the left-hand side, you see all the studies listed, and there's the flags of the world if you'd like to practice to see where the studies were conducted. And in the red square, you can see what the overall evidence was. So if we pull the data from the different studies, we can see that if smoke-free legislation is implemented in countries, there's a almost 4% reduction in the number of babies being born preterm. Similarly, we were able to pool a number of studies on children being admitted to hospital for asthma, showing that after smoke-free legislation, there was a direct reduction of almost 10% in the number of children having to go into hospital for severe asthma attacks. And not only was there a direct effect, we also saw that in addition to this direct effect, each year after the legislation was implemented, there was an additional 6% decrease in the number of children having to go into hospital for asthma. What we weren't able to assess in our previous review, but we were in this one, was whether there was an impact on lower respiratory tract infection admissions among children. And this was quite striking because if we pulled the data from 3 studies in 3 countries, we noted that there was an 18% reduction in the number of children having to go into hospital for severe lower respiratory tract infection admissions after smoke-free legislation was introduced. These findings are summarized in this slide. And as I said, we were also interested in whether the impact of the policy was larger if it was introduced in a more comprehensive manner. And here in the red arrows, you can see that when we only look at the comprehensive laws, that the impact was slightly larger, indicating that it's important that if you implement a smoke-free law, that you do it in a comprehensive manner. And this is in agreement with what we see in adult studies. Well, how important are these findings? This is a ranking of the childhood diseases and how much they contribute to the global burden of disease. And as you can see, 2 of the diseases which we identified as diseases being amenable to smoke-free legislation are the top 2 diseases causing disease among children in the world. So smoke-free legislation is an important way in which we can reduce this. We also looked at secondary outcomes, and after smoke-free legislation, we saw significant reductions in very preterm births, the number of babies having low birth weight or being small or very small for gestational age, and we saw a small but significant increase in birth weight on a population level. There were very few studies looking at other tobacco control policies, and I want to discuss 2 that looked at whether helping people to quit tobacco use from a government perspective would help improve child health. There was one study from Massachusetts where tobacco cessation coverage was introduced for Medicaid recipients, and they noted a 6% decrease in upper respiratory tract infection admissions among children after this was introduced. In another study across the US, there was no change seen in the number of babies being born preterm after introduction of optional medical enrollment policies to provide low-income women with stop smoking services. Finally, we noted a number of studies looking at the association between tobacco taxation and child health, and they noted, one of these studies noted a reduction in preterm birth, particularly among deprived mothers. Among 3 studies looking at the impact on asthma hospitalizations, a reduction was seen in 2. And there was one study showing a reduction in lower respiratory tract infections for each US dollar increase in state excise tax. Secondary outcomes for these 2 tobacco control measures showed mixed evidence for reductions in some child health outcomes. In particular, I'd like to mention a Canadian and a US study showing that there were reductions in infant mortality after increasing tobacco taxation. And we have later confirmed these findings in a study in the EU, and which I will show on my last slide. The findings that we saw were very robust to inclusion of studies that weren't of the highest evidence and exclusion of studies that had a high risk of bias. And we saw that some studies showed a variation in the association according to socioeconomic status, and if they did, they all showed that the policies had a pro-equity effect. So the impact was larger among the most deprived groups, showing that tobacco control policies have a potential to decrease inequalities among children. So I'll summarize the findings and then discuss some of the implications. In summary, smoke-free legislation was associated with clear and clinically relevant reductions in preterm birth and in hospital admissions for asthma and respiratory tract infections among children. Some studies also indicated that tax increases might have a positive impact, but there was very little information on other MPOWER policies and whether they impacted child health. We think that strengths of our study were that it was performed according to a protocol that was pre-specified and reviewed by experts in the field, that the search strategy was very comprehensive, that we identified and included a considerable number of studies and participants, that the findings are in line with our previous systematic review published in the Lancet and also with clear health benefits identified among adults after tobacco control policies are implemented, and that the findings were very robust in sensitivity analyses which we conducted. There are also limitations. It's difficult to study public health implementation of public health policies at a national scale, and therefore we used only the studies that were of the highest quality. There was little evidence, as I said, on policies other than smoke-free legislation, and among these other policies the findings were not always consistent, and we were unable to test whether there was publication bias, indicating that negative studies might not have been published. I quickly would like to go over why we think that tobacco control policies help children. How does this work? This is the most obvious route in which this works. So smoke-free legislation would decrease secondhand smoke exposure, also among children, but also among pregnant women, in the workplace, in schools, in public traffic, cafes, restaurants, and by doing so, improve perinatal and childhood outcomes. In addition, it has been shown that smoke-free legislation may increase the number of people trying to quit smoking and decrease the number of young people initiating smoking. By this, it may reduce smoking during pregnancy, and there's a number of studies that we included which actually showed that this happened, but also by lowering the prevalence of smoking in society, decreasing secondhand smoke exposure among children. And in addition, and this may well be the most important route, is that it has been shown in many countries that after smoke-free legislation is introduced, that there are social norm changes. So people take the norms that the government shows by introducing smoke-free legislation to their own homes, and they will make their homes smoke-free, and this is probably the place where children are exposed most and therefore protected most when smoke-free homes are implemented. And then there's the issue of third-hand smoke, which is the smoke that remains in curtains, in clothes, after the second-hand smoke is out of the air. And this may well be one of the mechanisms by which smoke-free legislation acts, but there's a definite need for more research in this field. We identified important knowledge gaps from our research. As I said, the impact of several of the MPOWER policies on child health is not known, and there needs to be more studies on this. We were unable to see whether the policies might have synergistic effects, so would it help to introduce smoke-free legislation and tobacco taxation at the same time, for example. There was little information on whether there is an impact on inequalities, which I briefly discussed. There should be more studies looking at the cost effectiveness of these policies, which is likely to be highly cost effective. And as you may have extracted also from the maps that I showed, there's no evidence on the impact of tobacco control policies on children's health and very little on adult health from low and middle income countries. And this is very important because these countries now carry the largest burden of the tobacco-related diseases. The implications are that smoke-free legislation needs to be implemented much more, that it needs to be implemented in a comprehensive manner, and that other tobacco control policies are also supported by impact on children's health. And I think this child health angle is very important for advocacy, because children cannot protect themselves. They cannot run away, especially not when they're small and even in the womb. And showing that tobacco control policies can help children be more healthy would be an important advocacy towards governments. And it's important that as new tobacco control policies continue to be rolled out across the globe, that their impact is being monitored so as to inform other countries on whether they are effective. This is almost my last slide. It's showing where we are now in the world. This is the different MPOWER policies and the percentage of the world population covered by them. And I did show you the map showing how many countries ratified the Framework Convention for Tobacco Control. And it's slightly disappointing to see the proportion of the world population being protected at the moment. And I think as more evidence becomes available, this may help inform governments which policies they should be introducing. So in summary, most children cannot protect themselves, and our research and the research by others has shown that governments can play an important role in protecting children against secondhand smoke and thereby improve their health at the population level. I'd like to end by thanking my co-authors on this piece who have worked together with me, and also thanking the funders that made this possible. And finally, this is the study that I was referring to, where we looked at the association between cigarette prices in the EU, in 23 countries, and infant mortality. And just to summarize, we showed that as the cigarette prices go up, infant mortality decreases. And interestingly, this is partly abrogated when cheap cigarette packs remain available. So it's important not to only drive up the prices, but also see where there's differences between cheap packs and more expensive packs. And this is something that needs to be investigated more also on other health outcomes. This was my last slide, and I'd like to thank you for your attention. I'm happy to take any questions. Thank you.
Thank you so much, Jasper. That was a great presentation, and it's really interesting to hear about the work that you're doing, and I think also about the next steps, I think, in terms of research moving forward as well. So we really appreciate that, you sharing this walkthrough with us today. We do have a few questions, and I would just like to remind participants that you can start to add any questions or comments that you may have for our presenter today in the chat section on the platform. So our first question today is looking at, are there any more, or do you have any more details or thoughts on when you mentioned the difference between comprehensive versus partial smoke-free legislation? I think what we're getting at is like what's involved in a partial smoke-free legislative measure versus a more comprehensive one.
Yeah, that's a great question. Thank you. So what we considered as comprehensive was when a smoke-free legislation was introduced at once in all public places. So that means bars and restaurants at the same time as workplaces were introduced, but also public traffic. And so comprehensive here means covering a lot of public places. And there's other aspects, obviously, of comprehensiveness which are important. So it needs to be checked that people are actually complying with the law. And for example, smoking rooms are not allowed, so as to really protect people who are inside. And all these recommendations can be found on the WHO website. And particularly among adults, it has been shown that the more comprehensive the laws are, the larger the health impact is. So it's really important to take this into consideration when implementing these laws.
Thank you, Jasper. That's really interesting, and I'm glad we can get more information on that as well. I think I'm going to jump to a bit of a related question. So I guess at the beginning of your presentation, you showed a slide on the where the studies were located in terms of North America and in Europe, and then the difference between local and national policies. So do you have any comments or thoughts on what the potential difference in impact between those local versus national policies would be?
We did not formally test for this, and if I eyeball the findings, I wouldn't say that there is a large difference, although I have a slight feeling that the countrywide laws are possibly more effective. I think the thing is that in Europe, the size of the countries is sometimes almost comparable to the size of states in the U.S., which might explain that the impact is as large. I think it is important to communicate with countries or states that are neighboring, and to see that the policies are that you try to align them, so that, for example, when it comes to taxes, people can't just cross the border of two states or countries to get their cigarettes much cheaper. Yeah, I think these are the implications. But from the data that we have, I can't say whether state or country policies were more effective.
Okay, that's great. Yeah, thank you. Thank you very much for your insight. So a couple more questions that are coming in. So we'd like to get your thoughts on, given that tobacco taxation is one of the more powerful policies to decrease the prevalence of tobacco use, how would you explain that it had such a little impact on child health?
Yes, I wouldn't say that it had little impact. I would rather say that we had much fewer studies on its impact, and because of the way the studies were set up, it was much more difficult to combine the data from the different studies to get sort of an overall estimate of what the impact of taxes would be. I also think that taxes are much more sensitive to the local situation, and I think that as more data will become available, for example, with the example that I gave on infant mortality, which is in all three studies studying this in 3 different countries, has shown that tobacco taxation is related to a decrease in infant mortality. I think as more data will become available, it's likely that we will see the impact better. But at this stage, yeah, it's not completely consistent, and it's difficult to explain.
Yes, absolutely. I think especially with I think looking at policy level impacts, there's a bit of a less of a connection, I think, or a clear connection there.
Yeah, and the other thing is that the impact might not be seen directly. Also in our study, which I presented in the last slide, we saw part of the impact only coming in after a year, whereas in smoke-free legislation, well, the legislation starts from one day at the other, and from that day you're not allowed to smoke anymore. So it's easier to detect a difference and to also relate it to the policy that changed.
Right. Yeah, absolutely. Yeah, thank you for your response. So another question that's come in is, and I'm not sure if you are as familiar with this, but even to just get your thoughts, as England is one of the countries that promote the use of e-cigarettes, it should reduce child and mother exposure to smoke. Have you, are you familiar with this? Have you noticed any effect for this yet? Or is this more of a new research area?
Yeah, well, it's a great question, and it is a new research area, and there's, well, every day there's new papers coming out. And I know it's also been causing a lot of debate, mainly, I think, between North American researchers and UK researchers about whether e-cigarettes might have any public health benefit. I'm not aware of any data relating the switch to e-cigarettes to whether children are less exposed to secondhand smoke and whether that might have an effect on child health. And I think before we can advocate e-cigarettes, for example, also for pregnant women wanting to stop smoking, I think we need much more data on how safe it is, and I think the data at present is well, at least conflicting. So I wouldn't dare make any recommendation about it, and I'm not aware of any studies having assessed their impact on children's health on a population level.
Thanks, Jasper. That's really interesting, and I think it's I guess really hard to. Well, hopefully in the near future we'll have a little bit more information, as it's such a popular topic in Canadian media right now. So our next question here is, and I think it goes back to one of the previous slides, so maybe I'll try to pull that up as well. But how do you explain the results of Canada in reducing asthma DALYs?
Let's see. Can you put up the slide that we are referring to?
Yes, I'm sorry. I'm just trying to.
I think that I know what you're referring to. It's the next slide, I think, isn't it? Yeah. So this one, there was one. There were 5 studies that we were able to pull when it came to the impact of smoke-free legislation on asthma admissions among children, including one Canadian study. And as you can see, this was the study which definitely didn't show a positive impact. And there's a few things that I can say about this study. It's that it was very small, so it was a very regional study, which you can also see from 2 things in this slide, which is slightly technical. But on the right side, you can see the weight, which is how much the study contributes to the overall result. And you see it's only 1%, whereas the other studies, their weight is much larger. And this is an indication of how much it contributed. And you can also see this by the confidence interval on the left-hand side, which is very wide. So although this point, which is at 11, suggests that there might have been an increase in asthma admissions, the uncertainty around this estimate is very large. So although we included this study, I think it's very difficult to draw conclusions from this single study and say that in Canada there wasn't an impact. I wouldn't dare say that based on this small study.
Okay, thank you. Yeah, that's a great clarification. So thank you for taking the time to go through that. I would encourage people to continue to please put questions into the chat box as you think of them. I think one more that I have here is you mentioned, I believe, at the end about how most or all of these studies were carried out in North America or in Europe. What are some of your thoughts or considerations for the transferability or applicability of these results to other countries, and maybe more specifically to low and middle income countries?
Well, there's a lot to say about that. I think important considerations are that there's much more variation in smoking rates among these countries. There's countries like China and India where smoking rates are extremely high, and there's some African countries such as Ethiopia where they're very low. So much of this relates to how much people are smoking. Much also relates to how many women are smoking, because females are probably the ones exposing the children most to secondhand smoke because they're simply caring for the children and carrying them in the womb when they're pregnant. If you look at smoking rates among women in low and middle income countries, they're quite low, particularly among during pregnancy. So if I would expect an impact. I would expect it mainly during childhood and maybe not in pregnancy. But given that the low middle income countries are much more populated and the vast majority of smokers is now living in these countries, I think it's very important that there is more research being done about what works in these countries to protect people from this hazard, which is also increasing at a higher rate than it is in high-income countries.
That's a very good point. Thank you. Thank you, Jasper. So a couple other questions that have come in as well. I'm not sure if, maybe I'll try to pull up a slide that might relate to this, but I'm not sure if you can recall off the top of your head, but for the study that was conducted in China, did it consider pollution as a confounding factor for pulmonary problems?
That's a great question. I do seem to recall that it did, but I'm not sure enough to comment on it, so I would have to look that up. But it's a study which I think was published in PLOS ONE, as I recall, but I'm not sure. But people can look it up in via PubMed to see more details on this particular study.
Yes,
I'm sorry, I cannot answer that.
Yeah, no, I think there were definitely a lot of included studies, so it's perfectly understandable. I would encourage people to go take a look, and if people do have other questions like that, then they can definitely also contact us after as well, and we'd be happy to look into that for you. Another question that we have here is, were there studies that looked at the effect of other MPOWER policies on child health besides the three that you have presented today? So I know that I guess the interventions that were, or policies that were included in your review focused on the POR of the MPOWER acronym. Were there any other ones that you saw or found or weren't able to include that perhaps were
no, so these were the only ones making a direct link between the policy and health outcomes. There's obviously studies looking at whether it affected their health behaviors, such as smoking rates or being exposed to secondhand smoke exposure, but these were not one of our outcomes. We were mainly interested in the impact on health outcomes. So we are pretty sure that using our comprehensive strategy, we were able to locate all the studies that were relevant in this field, and we didn't identify any studies on other policies than the ones that I presented. There was one study, however, which was not an MPOWER policy, which is interesting to mention. Was a study conducted in the US where they looked at raising the age for legal purchase of tobacco to 21, and this study showed a decrease in the number of children having to go into hospital for asthma. So this is another policy which we didn't include because it wasn't an MPOWER policy, but which has the potential to also benefit children's health directly.
Interesting. Thank you. Yeah, thank you for your response. So we have one more question here that's just come in. Are there any policies that or of these that you think that would be better for low socioeconomic children who are perhaps more affected, as you mentioned, by secondhand smoke?
That's a great question. I wish I had a good answer to it, because I think that's a real big struggle. Because I think if we're not acting, then these inequalities between high CES and low CES children will continue to increase. So it's definitely an area of interest, and from a policy level, we showed that some of these policies, or at least tobacco taxation and smoke-free legislation, had possible pro-equity effects, and yeah, we should be looking not only at governmental level interventions, but also whether health carers and local governments can do more to protect these children, to go into the homes and to tell parents about the dangers of tobacco and tell them to stop smoking and at least do not smoke near the children and not in your own home, things like that. But from a policy level, yeah, I think that there's some evidence that there is a pro-equity effect of these policies on children's health.
Absolutely, yeah. It's actually, I guess it's that balance between a more universal policy and a targeted intervention or program.
Yeah. So I'm not aware of any targeted interventions at the government level, or at least we didn't identify them in this review.
Okay, that's great. Thank you. So I think we are nearing the end of our time. I think I just have one more question that relates a little bit to this. So it was what I found really interesting at the end of your presentation here is your graph that I've just put up about the percentage of the population, world population, that's covered under these different types of interventions. And I was wondering if you had any kind of comments or thoughts on perhaps some of the more popular interventions and whether or not the more popular or more highly or comprehensive interventions that you have listed here and their effectiveness in relation to how heavily they're implemented.
I'm not sure I understand the question completely, but I think your question is whether the policies that are implemented more are also more effective?
Yes, yeah, absolutely.
Yeah. Well, I can't say from a child health perspective because the policies that are covering the largest share of the world populations are the ones that we weren't able to study because they simply, their relation with child health outcomes hasn't been studied. So from a child health perspective, I would urge countries worldwide to implement smoke-free environments because this definitely has an impact. And there's 80% of the world's population that currently isn't covered by comprehensive smoke-free legislation. So my suggestion would be to focus on that from a child health perspective.
Yeah, no, absolutely. From that perspective too, that makes a lot of sense. And it's really interesting to see that, I guess, perhaps discrepancy because the information is not available. So hopefully we'll see some research in that area as well. So before we do wrap up today, and if there are some last-minute questions, please feel free to continue to add them. But before we wrap up, I do have a couple more polling questions that I would appreciate if you'd answer. And again, please remember to press the submit button once you've selected your response. So really what we're asking right now is whether or not the information that was shared today was helpful in the work that you do. So I'll open up the polls, and we're looking for responses of strongly agree, neutral, disagree, or strongly disagree. So we will leave that open for a little bit longer, and it's really great to see that everybody is definitely thinking that they agree or strongly agree that the information today was useful to the work that they do. At this point in the presentation, we would like to share a few options for ways that you can interact with health evidence moving forward. So these include visiting our website, registering to receive our monthly tailored registry updates and or the monthly newsletter to stay up to date on new research and upcoming events. Tell your colleagues about health evidence. Follow us on Twitter using the @healthevidence handle. And we also encourage your organization to use health evidence to search for review-level evidence to help inform program planning and policy decisions. And please let us know and get in touch with us to suggest any future webinar topics or to provide feedback on this series. So with these potential actions in mind, we'd like to get your thoughts on what are your next steps after learning about this review-level research on tobacco control policies. So do you plan to access the full text of this systematic review? access the quality assessment for this review that's available on Health Evidence, consider using the evidence in your own practice, or telling a colleague about the evidence that you've learned about today. So we'll leave that poll open for a bit, and with that, that brings us kind of to the end of our question period. I'll just do a quick check, but I think it seems that we've covered everything. So I would like to give a big thank you to our presenter, as well as to our audience today for posting questions and for making this a very engaging and stimulating session. One final reminder before we go is that the copy of the webinar recording and the PowerPoint presentation will be posted online in the next week or so if you're interested. So thank you everybody for joining us today. And I guess Dr. Been, do you have any final words that you'd like to add?
No, I'd like to thank you for your invitation, and I'd like to thank the participants for asking these great questions, and hoping to take this more forward in the future. Thank you very much.
Wonderful. So thank you very much for taking the time out of your day, and good afternoon to everyone, and thank you for joining us.